Hello, Sue.
Oh, hi, how are you?
Pretty good, and you?
Not bad.
So you got the link today. You didn't. You said that
Yes.
yesterday you were having trouble getting your email appropriately.
No, that's right. No, I got it today.
Oh, that's good.
Worked out finally. Or I
How
worked
have you
out
been? Have
finally.
you?
Very busy practicing physical therapists. And I'm sure I've got patients waiting to see them. I'm really very pleased that they could do this for us today. We are going to hear from Alison Radomski, who I know because she was my physical therapist when I did balance physical therapy, and I found incredibly useful and very interesting talking to Alison about issues of balance. She is a doctor of physical therapy, and therefore I think is entitled to the title of doctor, like many of us here who've never delivered a child. And she is a physical therapist at Penn Therapy and Fitness, University City, and she's been there since February 2019. She graduated from Newman University with a Doctor of Physical Therapy degree in 2018. And she spent her early career working in inpatient rehabilitation. She has clinical experience working with a variety of neurologic and orthopedic diagnoses. We will also be hearing from Christina Pettet, who is also a doctor of physical therapy and a physical therapist at Penn Therapy and Fitness. She received her doctorate degree from DeSalle University in 2017. She holds a certification of competency in vestibular rehabilitation from Emory University, and her clinical expertise includes treatment of concussion, mild traumatic brain injury, headache and migraine, and vestibular disorders, where she utilized an integrated multiple system approach. So I'm going to hand it over to our speakers. If you have any questions, please put them in the chat, and hopefully we'll have some time at the end where I can gather them all together and ask them. So Alison, I don't know who's going first, but it's you or Christina.
Sure, thank you, Yvonne. So again, I'm Alison Radomski. I'm going to switch over to share our PowerPoint here.
Diane, can you find John Lee,
Okay, so today we're going to be talking about understanding and prevention of falls in the aging population. I'm just going to stop my video here so we can focus on the PowerPoint here. Okay, so some of the things we're going to go over today, some of the goals are to help everybody here understand the prevalence and different risk factors associated with falls, learn a little bit about the physiological systems in our body that help control balance, and then specifically, Christina is going to focus in a little bit on the vestibular system, which is one of the systems that plays a large role with different balance and different reflexes. We're going to talk about some different tests and measures that would quantify your risk for falls. So some of these are ones that we would do in physical therapy. Some are a few that you could try out at home on your own, so we could get a little bit of an idea of where your risks are compared to the research and compared to other people in your age group. And then another goal today is going to be learn some ways to help improve your balance and reduce the risk of falls or injuries in the future. So who is falling? So annually, this information is from the CDC here. Annually, at least a third of adults age 65 and plus have at least one fall. A small percentage of these falls are unavoidable. Some have a single precipitating event, so something comes out in front of you, you step in a hole, something like that. And then 17% are related to other risk factors, which obviously you can see the bulk of these here are from these other risk factors that contribute to falling. And we're going to talk a lot about that in a minute, what these risk factors are, what are modifiable, and what ones are something we can't really change. And then research shows that if you have at least 4 of these risk factors, you have a 78% chance of falling within a year. So as we talk about the risk factors, once you just kind of keep track of any of these seem like they apply to you, because it can add up to 4 or more quickly. So the effects of falls, 20 to 30% result in moderate to severe injuries, including fractures, traumatic brain injuries, and then this is one of the leading causes of unintentional deaths for people age 65 plus. And the annual healthcare cost of things related to after falls is $49.5 billion. This is obviously a very large toll on our health system, especially when some of these things can be prevented. So this algorithm here, this is from a recent study published in the New England Journal of Medicine. And the goal of this is to have every primary care physician use this to help screen all of their patients who are 65 years plus. So as we go down and answer the questions, if you've had a fall, if it's been related to syncope, you're feeling like you're passing out, do you have a fear that limits daily activities? It would separate you into a mild, moderate, or a high risk with the falls, and that would dictate how the primary care physician is supposed to proceed from there. So even if you haven't had a fall and you don't feel that you have a fear of falling, they still recommend that the primary care physician prescribes exercises for general health that may include some fall prevention exercises, just to get you a little bit better now before you're actually at that higher risk. And this category here would be if you were at a moderate risk. So in that case, then the doctor is supposed to screen you for balance, your gait, how you're walking, most likely prescribe physical therapy, talk about assistive devices, and things of that nature. And then if we fell into this high category over here, to where we've at least had one fall, but it doesn't necessarily have to do with syncope or, again, passing out, that we would likely proceed with a multifactorial management. So this would include following up with other specialty doctors, cardiovascular, taking a look at all your medications. So just really looking at every aspect of this and how we can prevent you from having more falls. So going over some of the risk factors of falling, and again, keep an eye, try to keep account on if any of these apply to you. So previous falls is one of the greatest risk factors to having another fall. This one seems a bit obvious, but if you have any balance or gait impairments already, that makes you riskier for having a fall. Vision impairments, orthostatic hypotension. So this can be related to medications. It can be related to a general dietary or nutrition status. But that feeling when you get up too fast that your blood pressure drops, things start to get a little bit dark. If that happens to you frequently, that puts you at a risk for falling. Polypharmacy, which is taking 4 or more medications. And these are any prescribed have a lot of side effects with dizziness and hypotension. Same with any psychoactive medication. So any sedatives, antipsychotics, antidepressants, they also have that high side effects of arthritis, any decreased muscle strength or a lower body weight, you're at a higher risk for falling here. And then obviously some of these are not ones we can control too much, such as if you're a female or if you're age greater than 80, just one of those natural inherent risk factors for falls. And the last one here, environment, has to do with your home setup. If there's any clutter, the environment outside, if sidewalks are uneven, things like that, obviously leads to higher risk for falling here. But we're not going to spend a ton of time talking about this, but this is just what some research shows and showing some odds ratios. So, how related are these things with having a higher risk for falls? So I just want to highlight some of the higher ones here. Gait problems. So one, if you feel like you're not walking, kind of that normal pattern that you would see, but the biggest way to test for this is your gait speed, how fast you're walking. And later on, we'll talk about a test that we can perform to track your gait speed and what your speed means in different environments. And then another one here that has a higher odds ratio for falling, balance impairments. And that really has to do with the 3 different systems that we're really going to get in here today. So your vision system, your somatosensory system, and your vestibular system. If any of these are affected, it really gives you a higher risk for falling here. So this is a model of 6 different things that affect our postural control, which is the way our central nervous systems kind of regulate information from various systems to help maintain a controlled upright posture. And these systems need to play a role when you're doing static or dynamic tasks, in sitting, standing, if you're on your hands and knees, or if you're walking, everything has to piece together to keep your body upright and keep your body stable. It also has to do with contracting the appropriate muscles and your body being able to make small adjustments in response to changes in this environment or any movements. So if one of these systems is not working correctly, the others can be trained to compensate. So if we talk a little bit about our biomechanical constraints, this has to do with your range of motion, your strength, things of that nature, your stability or your limits of verticality. This has to do with if you're reaching kind of outside your base of support to where it feels like you're really leaning over. Our body needs to be able to adjust and counterbalance those muscles to where we stay upright. Anticipatory postural adjustments. This is when we basically have those reaction times, right? So how does our body react to a changing surface, or if you shift a little bit, what else do we have to do to help stabilize? And then if we get over here into sensory orientation, this has to do with those 3 systems that we're going to talk about. So your visual system, your somatosensory system, and your vestibular system. And then obviously the last one, stability and gait. So while we're walking and doing dynamic movements, how is our body responding to help keep us upright and stable here? So we're going to switch it over to Christina now, who's going to talk about those 3 systems and get into some different vestibular disorders here.
Great, thank you, Alison. So as she said, kind of piggybacking off of what she just went over with regards to sensory organization, we're going to start with going over a sensory motor integration for postural control. So we use information from these 3 systems that get sent to the brain to allow for processing. So those 3 systems include, and we're going to go into these systems in a little bit more detail in the upcoming slides. So the first system is your somatosensory system, which allows input from the periphery to get sent to the brain. And you can see on our description there on the PowerPoint slides, you can see the hand there for the somatosensory. And then you have your visual system, which involves the cranial nerves 3, 4, and 6. So ocular motor nerve, trochlear nerve, and your abducens nerve. And then our vestibular system, which includes sensory input that gets sent to the brain to allow for sensory processing. And then from the brain, they produce a motor output, which allows you to help stabilize or control your posture, balance, and reflexes. So I think that kind of visual there on that right-hand side gives you a nice description that you're getting all this information from the periphery through your vestibular system, your auditory or vestibular system, and your somatic sensory system, which is relaying that information to the brain to allow you to maintain your posture and stability and your reflexes. Moving into the somatosensory system. This system is a network of neurons that relays information from the periphery to the brainstem. It provides relative orientation and movement to the body in relation to its support surface. So this system includes tactile and proprioceptive stimulation, including pain, temperature, touch, proprioception, and vibration. So if you think of the example of pain, if you were to put your hand onto a hot stove, your your sensation from the hot stove and the pain from the periphery would then send a signal through the spinal cord up to the brain. And then your brain would then kind of process that signal, say this is a noxious stimulus, this is painful, and then send a motor output or a reflex back out through your limbs to allow you to move your hand and lift your hand up versus holding your hand there and increasing that pain stimuli. For our visual system allows for the ability to perceive movements and detect orientation of the body in space. When we think about vision, we have kind of two main visual systems here. So we have focal vision, which allows for localized features in the environment and in our conscious reaction to the visual events. Then we have ambient vision, which utilizes the entire visual field to provide information using largely non-conscious awareness. If we kind of think of an example of this, consider if you were walking and looking at your phone. So your focal vision would be you focusing on your phone, your conscious reaction, reading whatever is on your phone. And then your ambient vision would be noticing if there was anyone around you or any objects around you that are in the way, so that your body can respond and react so that you limit falls or have to make any kind of modifications necessary, which is that non-conscious awareness. So that can help with contributing to righting reactions of the head, neck, and trunk. And then we're going to spend a little bit more time talking about the vestibular system, as that's one of my areas of training and where I see a lot of my patients in physical therapy with vestibular influence or vestibular therapy, vestibular deficits for physical therapy. So what is the vestibular system? As we mentioned, it's that system, a peripheral organ within the inner ear. It provides a central nervous system with sensory information for motion, head position, and spatial orientation with relation to gravity. So this system in particular detects angular and linear acceleration. When we the central aspect of the vestibular system, your central control, you have your cerebellum, which is essentially your coordination center. It's what maintains that kind of calibration of your VOR, which we'll talk about in a little bit as well. But this is your coordination, your ability to really move and have your balance stable there. And then you have your vestibular nuclei. This is your relay station. So this is the part of the vestibular nerve or cranial nerve 8 that transmits sound and balance information from the inner ear up into the brainstem. So if you look at this picture on the bottom right again here, you have your vestibular organ inside the inner ear.
Mom,
What?
just wait till she comes up the driveway.
Okay, yeah, but I'm trying to.
There's a couple microphones on in the background, if everybody can just make sure that they're able to mute. So you have that vestibular system within your inner ear, and then that system is reacting to sensation from the periphery that will get sent through the vestibular nerve. So that information gets relayed through the vestibular nerve here and gets transmitted to our relay station or our vestibular nuclei. That nucleus will tell the spinal cord or the brain basically where to send that information. So does it need to go down through our vestibular spinal tract into the spinal cord, or is that information going up to the brain and the brainstem to help maintain our balance and reactions there? And then going back to the other part of the vascular supply, you have your internal artery and your vestibular artery, which provides the blood flow. And then we have our motor output reflexes, which are responsible for our postural stability, eye movement, and gaze stabilization. We're going to break those down on the next slide. So our motor output reflexes. So what are they? You have 3 different reflexes. First one being your vestibular ocular reflex, which is usually the one that people are most familiar with, or your VOR. This reflex allows for maintaining stability of your visual image during head motion. So if you were to, our typical test for this, or if you were to keep your eyes focused on one target, I would have you move your head from side to side while keeping your eyes focused on that target. So your VOR is allowing you to see a clear image while you're moving your head. So it's allowing that clear focus without having any kind of blurriness or kind of decrease in balance stability as you do that. Your vestibular colic reflex, or VCR, is a reflex within the neck musculature that activates to help stabilize the head with different changes in position. And then your vestibular spinal reflex, or your VSR, is a compensatory body movement to maintain postural stability to prevent fall. So again, in that picture there on that right-hand side, you can see that he has this reaction to where he's tilting over to his right, but he's utilizing his, in this case, his VCR and VSR to maintain upright positioning of his head and neck and his trunk, or else if he didn't have these reflexes working, he would be kind of situated in a complete diagonal. He doesn't have that righting reaction to get his body back to midline or to neutral here. Okay, and then moving into the peripheral vestibular system. So again, when we talk about the vestibular system, you can really break this down into a central vestibular system and then the peripheral vestibular system. Central meaning brainstem and spinal cord, and then peripheral meaning it's coming from the peripherally, truly from the inner ear, the vestibular organ in itself. So we're going to spend a little bit of time talking about the peripheral vestibular system, again, which is the inner ear and the pathways to the brainstem, because this is a majority of the common origin for patient signs and symptoms when they have a sense of dizziness or imbalance. So the three primary functions here of the peripheral vestibular system are to help maintain visual images during head motions to allow that clear vision. So our VOR there, maintain postural stability during head motions and provide information for spatial orientation. If we break down the anatomy a little bit more, this system involves 3 semicircular canals that respond to angular acceleration. So you have an anterior, a posterior, and a horizontal canal in each ear. So you have 6 canals total. And that's the picture of the blown up image here. Again, on that right-hand side, you can see those 3 canals within the inner ear there. So that will be important for as we talk about various diagnoses of why people have dizziness or imbalance in a little bit. And then you have your 2 otolith organs, which are your utricle and your saccule, which respond to that linear acceleration or static head tilt. Is everybody following me here? Are we doing okay?
Yeah, you do fine.
Okay, I'm not losing anybody. So why are we going over this? Why are we talking about this? So if we talk about the vestibular disorders, this can occur when there's any disruption of the sensory information processed by the inner ear and the brain with respect to the body's control of balance and eye movements. So these disorders, and there's a large chunk of them, and we're only going to talk about 2 of the main ones today. But they can kind of encompass numerous specific diagnoses. And again, they're either classified as peripheral or central, with the majority of cases being, truly from that peripheral vestibular system versus anything central coming from the brain. And Alison kind of touched on this a little bit, but making note that not all, etiologies of dizziness or altered balance are classified as a vestibular disorder. We have to take into consideration other aspects of why people could have this dizziness, such as hyperventilation, dehydration, stress or anxiety, fatigue, neuropathy, or any cardiac diagnoses as well. So when you come into the clinic and someone's looking at or doing a vestibular screen or vestibular eval, we're always trying to, rule in or rule out central or peripheral vestibular deficits, and that kind of tailors our exam and our treatment for this diagnosis. So what happens to the system with age? So with age, approximately 40% of dizziness is estimated to have a vestibular origin. Adults with symptomatic vestibular dysfunction are estimated to have a 12-fold increase in the odds of falling. So again, it's increasing your risk of having falls. There is a documented critical decline in vestibular capacity with age. This includes hair cells and neuronal degeneration of the vestibular nuclei and the cerebellum. And then patients with unrecognized BPPV are more likely to have reduced activities of daily living scores, sustained a fall in the previous 3 months, and have a kind of secondary complication of depression. The first of the disorders that we're going to go over today is benign paroxysmal positional vertigo, or what you might have heard of as BPPV. So what is BPPV? BPPV is an inner ear condition that causes short, usually 30 to 60-second periods of vertigo when the head is moved in certain positions. So the typical presentation of this is that, somebody comes into the clinic, they say, I woke up, or, I got out of the bed first thing in the morning and I had this intense feeling of this room spinning dizziness, and they usually say it was awful. There might be some associated, nausea or vomiting with it. Sometimes people can tell that they do have this abnormal eye movement or nystagmus, but not usually. That's something that we'll see more in the clinic. And then after that dizziness kind of subsides, they're usually left with this generalized imbalance with standing or walking. Why does this occur? So what's happening here, and there's a video to go over in the next slide, is that the otoconia, or the calcium crystals in your inner ear, which is actually that picture on the bottom right, those are otoconia within the inner ear, and you have, multiple of these crystals. But what happens is that they break loose from the utricle where they're supposed to be, and they travel into those semicircular canals I was talking about earlier. And that's what's causing the vertigo or the dizziness, is that you're feeling these crystals kind of free floating around the inner ear when they should be really adherent to the utricle versus migrating through the inner ear and through those canals. So what's the treatment for this? It's typically vestibular rehab therapy. Specifically for this diagnosis is performing the cannula repositioning maneuver. And then this is a video, hopefully the sound will work here, but this is a video that's going to give you a little bit of a depiction of what's happening when you have BPPV, and talk about those canals and the crystals specifically. So this is looking at the posterior canal. Alison, you might have to turn your microphone on, or maybe. Is that doing it? I'll kind of explain it to you. So that's looking at the posterior canal. This is then going over the Epley maneuver, or the treatment for this condition. So what they're doing is they're putting their head 45 degrees to the right and lying you back towards that right side. And then what we're looking for as clinicians is we're looking for that nystagmus, or this kind of involuntary eye movement here. And that's telling us, what's going on with that vestibular system and what canal and what ear is involved for the positive testing. And then the treatment would be to have you kind of flip over to the left and then roll over to your other side again. And what we're doing is repositioning that crystal out of the canals and then back into the utricle there. And then from that position, they have you sit up. And then here's a nice depiction of what's happening. So that red thing right there is our otoconia, or our calcium crystal. It's floating, kind of free floating in this endolymph fluid. As they're bringing their head down, that crystal is moving to the most dependent position. So gravity's pulling that down to the most dependent position. And then the maneuver is putting it back into where it needs to be. So the endolymph fluid itself is not what's causing the dizziness. You're getting the dizziness because of that calcium crystal moving within that fluid. So as you can see through that maneuver, you're migrating it through that canal to go back into the utricle where it, typically would stay there. And this is a very simple, skilled maneuver. It usually only takes 1 or 2 visits, or 1 or 2 of the maneuvers. And, this is then cured, and people can typically go about their normal routine there. And then let's go on to the hypofunction. So the other common, BPPV is the most common vestibular diagnoses that we see. and is the most common cause of that, again, that room spinning dizziness. It has to be linked to or affected by some type of positional change. This isn't any dizziness that you're going to experience if you're just sitting still and not moving. There has to be some type of head motion or change in position that's causing the dizziness. So the other aspect of it is a vestibular hypofunction. So with a hypofunction specifically, again, this is a peripheral vestibular dysfunction, so it's not central. You can have either unilateral, meaning one side affected, or bilateral, so both sides involvement. The typical presentation for this type of dysfunction is usually an acute vestibular crisis. So you, again, have this kind of bout of severe intensity of dizziness. This may be different than the room spinning. This may be more of a nausea or a vomiting episode. And then it's usually followed by either continued dizziness or vertigo, poor balance, especially with those head turns. So something that's focusing on that vestibular system or testing that vestibular system. Difficulty walking, specifically outdoors, darker environments when our vision might be impaired, or crowded places, and then nausea. So why does this happen? There's a few different causes of why this can occur. So there, when you think of the two main ones, you think of a vestibular neuronitis or a vestibular labyrinthitis. That is a viral or a bacterial infection that's attacking the vestibular nerve. So what that's doing is causing weakness of the structures of the inner ear. Sometimes due to aging, sometimes it's following like an acute respiratory or GI type of symptom or infection. Sometimes there's associated, if it's on the labyrinthitis spectrum, it's associated with a decrease in usually unilateral sensory neural hearing loss. So you do have typically a change in your hearing. As well as some medications can cause a disruption of that peripheral vestibular system. If we think of our chemotherapy medications or some of our medications for our psychological treatments is also a common one. Bipolar disorder is the medication for that is common to affect the vestibular system. So also taking a look at medications and if there's any impact to those on that system. And the treatment for this, again, is vestibular rehab. So what is vestibular rehab? So vestibular rehab is a specialized group of physical therapy completed from trained vestibular physical therapists with a very high success rate if it is truly, coming from that vestibular system. The interventions focus on compensation, adaptation, and plasticity to improve the vestibulo-ocular control and subsequently increase motor control and movement. Our main goals are typically to improve static and dynamic balance, reduce the rate and risk of falls, improve strength and range of motion, minimize, if not eliminate, the dizziness, and then reduce dependency on those other somatosensory systems. So reducing dependency on your visual system, and then somatosensory information, so that the vestibular system is truly working and is able to, use maximum capacity there to help hold your balance upright and limit those risk of falls.
Okay, so now we're going to talk a little bit about what are some of the indications if you have any balance things or have any issues with any of these systems that we've talked about. What are some things that would kind of lead a good case for physical therapy? So if you came into physical therapy, let's say you went to your primary care doctor, hopefully they went over the different risk factors with you and decided, let's get you in to see a physical therapist. So you would come in for a full evaluation by somebody that specializes in falls risks assessment. We would take a look at your balance and your different systems, including your somatosensory, your vestibular, and your vision system. Take a look at your functional mobility. So how you're doing with walking, how you're doing with transfer. So getting up and down from chairs, walking and turning, and then obviously take a look at your range of motion and your strength to see if there's any orthopedic things going on that may be causing you to have a higher risk for falls. And then we would prioritize and target a plan of care to reduce the risk for falls and to see which of the modifiable risk factors you have and how we could help with that.
Somebody mute that noise. What is it, mute?
It was somebody else's.
Okay, we seem to be all right again.
We're okay? Okay. So if you would come into physical therapy, or there's also some ones that your doctor might do, we'll talk about some ones that you could perform on your own. So different standardized outcome measures. So these are different tests. Some are subjective, but most are objective measures that help identify impairments, to figure out if you have any activity or participation limitations, and they help guide our plan of care and the choice of what therapeutic interventions we would do, targeting what you have going on. And again, this would help to isolate which intervention would be most effective, basically based on the research, how that translates to clinical practice and outcomes with patients. So the first outcome measure, and we touched on this a little bit earlier in the presentation, is gait speed. So there's been some saying that, you know, speed is the 6th vital sign, and it's actually very important with different aspects of your mobility and walking. So a preferred gait speed, we're going to use that term a couple times here, is basically your self-selected speed. So how you would walk at your normal pace, not feeling like you're rushing, but just your normal pace walking. So research shows that if your self-selected gait speed, as we see here, is below 0.6 meters per second, you would be a lot more dependent in ADLs, that's your activities of daily living. You'd also be more likely to be hospitalized. People that are below this 0.6 meters per second, if you're over here 0.4 meters per second of gait speed, you're a little below that safe cutoff line to be a household walker, which means you would be safe walking around in the home. If you're between 0.4 and 0.8 here, you would be a limited community ambulator. So you could go out some, you wouldn't be the safest if you were walking a couple blocks outside. That comes more up here, 0.8 meters per second or higher. That makes you more safe for things like crossing streets, getting through revolving or automatic doors, things like that, when you have to speed up out in the community to keep it safe here. And some other gait characteristics that are associated with a higher risk for falls are decreased velocity, right? So that, again, that's speed, decreased step length. So if you're taking short shuffling steps, that makes you at a higher risk for falls, or if you have an increased step width. So this happens a lot with people that are trying to widen their base of support to make them feel more stable. So it's actually a compensatory thing that your body does a lot of times, is to increase how wide your base is. So those wide steps show that you're at a high risk for falling. Now we're going to get into a couple of these other outcome measures here. And at the end, I have a handout with these two and some other information, because these two tests are probably the easiest to perform on your own, or if you have one person with you that could help time, or just stand nearby for safety. So the first one is the timed up and go test. So basically for this test, you're just going to go from a standard chair. You're going to walk to a line that's 3 meters or roughly 10 feet away. If you're trying this out at home, best thing to do is you know, put a piece of tape or put something small down, like a bottle on the floor, just as a marker, 10 feet away, and then turn around and come and sit back down in the chair. So if your time on this is greater than or equal to 12 seconds, that shows you're at a higher risk for falling. And the next easier outcome measure to perform on your own here, it's called the 5-time sit to stand. Again, we're going from one of those standard chairs, and you're trying not to use your hands. Basically, you just stand up and sit down 5 times in a row, as quickly but as safely as you can. And then a time greater than 15 seconds says you're at least a moderate risk for falls. And then here are some averages based on age. So you can kind of take a look, you know, if you're in the 60 to 69 range, most people would score around 11.4, 70 to 79, 12.6, and then 80 to 89, our times increase a little bit here, so 14.8. So as you can see, this average for the 80 to 89-year-olds is already very close to the risk that time that puts you at a moderate risk for falls. So age certainly plays a bit of a role here. Okay, now This next outcome measure is interesting because it combines those three systems that we talked about, right? So the somatosensory, the vestibular, and your vision system. So this test, the MCTSIB, is the modified clinical test of sensory interaction and balance. So there's 4 different scenarios. We would stand on a firm surface, so a solid floor, with your eyes opened and then with your eyes closed. And then we would repeat that standing with your eyes open on a foam surface and then your eyes closed on the foam. So if you have a loss of balance in condition 2, so that's when you're standing on a firm surface with your eyes closed, shows you're very visually dependent. So we remove your vision, if you lose your balance in this scenario, then you would be more challenged with those things. Christina mentioned a bit of, walking around in your house at night when there's limited lighting and things like that. If with this test you had a loss of balance in conditions 3 and 4, that would indicate some deficiencies in your vision or your vestibular system. So if we look over here on the right, the normal role of our systems, if we're standing on a firm surface, 70% of it is our somatosensory system. So that's, what Christina talked about a bit earlier with that sensation and then the motor output from the body. And then 20% on a firm surface is vestibular and 10% is the vision. So not a lot, if you're just standing on a nice firm surface with your eyes open, not a lot is coming from your vestibular and your vision system. So if we're standing on a compliant surface, such as foam, or in real life, this could be on grass, on a squishy carpet, things like that. So we can see it goes up to 60% reliance on your vestibular system. So if we're standing on something pliable, a foam surface, and you have a vestibular deficit, you'd be at a much higher risk for falling here. These next 2 outcome measures, I just wanted to mention, they are more functional outcome measures that we would do in physical therapy here, but these are 2 of the most popular ones that we do in our clinic. So the first one here is a Berg balance scale. It's basically a 14-item list to objectively measure your safety with functional tasks. And there's really good psychometric properties for ages 60 to 80 plus. This takes a look at things, if you can get up from a chair and go to sit on a mat, if you need use of your hands, how you would do with things like standing on one leg, standing one foot on the other, and then would give us a total score to show your risk for falls. The next one here, the functional gait assessment. This is more higher level tasks while you're walking. So this test looks for your postural stability and your performance on dual motor tasks while walking. And this gives a risk for falls and averages scores from ages 40 to 89. So in this measure here, the functional gait assessment, it looks at things like walking while you're turning your head, walking and having to step over an object, which really more relates to how you would do out walking in the community with some of these more dynamic challenges. As we go back here to indications for physical therapy, so from a 2012 Cochrane review, interventions with the greatest effect include working on standing balance while we're limiting your upper extremity support with a minimum dose of 50 hours. So that's a combination of direct treatment and independent exercises. So this wouldn't mean you would need to come in for 50 hours of physical therapy, but it can take up to 50 hours of doing things in the clinic with physical therapists and then what you're working on your own at home to really see the effects of the balance training. And then group exercise settings, which can be very popular and can obviously have their benefits, that do not specifically tailor balance and strength exercises based on what some of your outcome measures say, based on what we find with some of the evaluations of your systems, that is not as effective. Now, this information here is from the APTA, so the American Physical Therapy Association, from a clinical practice guideline about falls and treating patients with falls, what some of the evidence shows is most effective. So there's very strong evidence based on good research, so systematic reviews, randomized control trials, that individually prescribed and monitored strength training, balance and gait training, and then correcting environmental hazards. So things in your home that might be giving you a bit of a higher risk for falls that you could trip over, things like that. There's some moderate recommendations that taking a look at your footwear or any structural foot impairments and modifying those things could decrease your risk for falling. And then there's grade D evidence for educational information on falls prevention. So, you know, grade D evidence is not the strongest evidence, which makes sense. And if we think about just coming to this talk today, if we hear this information, it doesn't necessarily, unfortunately, decrease our risk for falls, but more sparks that idea of what do we need to look at and what do we actually need to do to decrease your falls risks and get better with that. All right, now we're going to go over some different benefits of more specific exercise programs. So structured group programs, home-based exercise programs, and Tai Chi recently has had a lot of research and evidence to show a reduced rate of risks and falling. Older adults with chronic disease have a long-term beneficial mortality effect from exercise program participation. So not even just on falls, but you know, if we decrease that risk for falls, it can, you know, prevent future injuries, which lead to other morbidity issues. And then there's no shown effect on falls risk with a brisk walking program, but it does have other health benefits. So if we're doing a lot of walking for exercise, obviously great cardiovascular benefits, but that won't necessarily prevent you from falling in the future. So what are some things here that we can do to help reduce your risk for falls? One big thing is reviewing home safety. And at the end, I'll show some resources and information that have some good handouts for what do you need to look for in your home that could cause you to have a fall in the house. Next would be having your healthcare provider review all your prescribed and over-the-counter medications. As we went over before, that polypharmacy, so taking at least 4 prescribed medications causes a higher risk for falls. So really sitting with the healthcare provider and making sure there's no redundancy in your list of medications, talking about the side effects and how some of the medications might interact. And then completing an eye examinations every 1 to 2 years, just to make sure there's no visual issues that may contribute to falling. Using strategies to help manage if you have orthostatic hypotension or if any of your medication side effects are orthostatic hypotension. And then addressing and seeking treatment for those other risk factors. So cardiovascular, if you have any orthopedic or musculoskeletal pain or issues, any hearing or neurological issues that we might find, and then urinary incontinence and vestibular disorders. So as we talk about going back to that home safety, about 50% of falls occur in the home and can be prevented. So again, we'll show some more information on that later of what you need to look for in the house to help for that. So to some take-home points here, just want to make clear that falls are not just a result of the aging process, and they can be prevented with a few simple changes, especially to some of those modifiable risk factors. So, you know, just don't think if we're getting older, falls are bound to happen. That's not true, and we need to do everything we can to prevent them. So again, falls risks can be reduced or managed. It's important to talk to your healthcare provider about annual falls risk and what can you do to help prevent it, and then figuring out what specific exercise programs are effective in reducing the risks of falls. There's a few resources here, and I have a handout at the end that I can email out to everybody that has this information. So the first one, the National Council on Aging, they have a quick, easy 12-question survey on there that can show you your risk for falls. So I would definitely recommend going on and taking a look at that to get an idea where you're at. And then the National Institute on Aging and the CDC, they both have a lot of fall prevention resources on there. And the NIA here has a handout about tips on what to talk to your doctor about, especially sensitive issues related to falls. Just wanted to highlight this. So this is Silver Sneakers, which is a program through Medicare. They now have a lot of online classes and workshops. Obviously, with everything being shut down for COVID right now, it's tough to find a good program to get out to for exercise and workout. So if you want to go onto the Silver Sneakers website, they do have some great classes that can focus on balance and things of that. And these are just some local locations. If you want to take a look, again, we can send this out for when things open back up. If you're interested in any of group fitness classes or Tai Chi, which is a low impact, group class about balance, you will have some ideas of where they are locally around here. Okay.
Okay, thank you, Alison and
Thank
Christina.
you.
Yeah, very helpful. So a couple of questions. You mentioned that low body mass index is a risk factor. Why is that? Would have thought it would have been the other way around, actually, that obesity would be a risk factor.
So I'm sorry, was that why a low BMI is a risk factor?
Yeah.
A lot of it has to lower bone density, and that just makes it more of a higher risk for falls.
I see.
Yeah.
So it's an indicator of frailty, I think is what you're saying, right?
Yes, and also issues, your overall energy level, things like that. So if that's low, some of those other things could cause falls.
And then I've always wondered, so is there any way of rescuing yourself when you start to fall? Is there a kind of good way of falling, I guess is what I'm saying?
I guess I would say the best way is obviously not to fall, right? I wouldn't say there's a method that we would go over of, hey, you're having a fall. If you can, try to grab on something and lower yourself to the ground as best as you can, especially if you're up and walking, if you're starting to feel dizzy, starting to feel unstable. First line of defense is try to get yourself into a seated position before the fall happens. But we do also in therapy work on some reactive balance training. So if you were to trip, if something were to surprise you and you start to have a loss of balance, how quick can your body react so that you are able to catch yourself?
So Janice Madden asks, she read an article in today's New York Times on falling, and the suggestion was made that walking on uneven circumstances can improve balance and reduce falls. So what are your thoughts on that?
I would definitely agree with that. I would just, give you that kind of mindfulness or awareness of that's something that is definitely a higher level balance task, and be mindful doing that at home if there's nobody around. But that is definitely something that we utilize as a balance training when you are in therapy, having you walking on uneven surfaces, we have different like yoga mats and therapy mats that we can have you walk on. We have multiple different like balance machines and kind of fancy equipment that work on that balance reaction on those uneven surfaces. But it's functional, and it's something that you're going to, if you're a community ambulator, that you're going to come across and experience. So as a component of your balance program, I definitely think it is helpful, but somebody should really be around when you're doing it for safety.
Right. Yeah, I always found it interesting that whenever I fall, I'm walking in the streets of Philadelphia. Perhaps that's not so surprising, but I do wonder how I managed to walk around the volcanic rock on an island in the Galapagos and not fall at all. I step outside my door and I fall, within a block. So Dr. Melise has asked, do spinning classes help restore balance and prevent falls?
I would say they can certainly help with some of those other risk factors. So if you have any weakness or any endurance issues, they can help with that. I wouldn't necessarily say that a spinning class on itself would help to prevent falls. It obviously works on, I'm assuming, some trunk balance, but I haven't really seen any research looking at spinning classes and directly how it relates to falls. So it's a bit hard to say. I don't know if there's a direct correlation there.
Yeah, if you're on something stationary, I would agree.
Yeah, so another question that's come in is, what is the number one home improvement to help prevent the most common falls? Is it rolling up all your rugs, for example? Putting bars in the shower, hang on to, etc.
Yeah, I would say the number one home improvement would be to take a look at your house and see what the issue is, right? It's not that everybody has to roll up any throw rugs, but if that's something you trip over, absolutely. You know, probably clearing clutter, especially in tight areas and hallways or tighter bedrooms and things like that, to make sure you have space and there's nothing hidden at your feet that if you were to get up when it's a little bit later at night, things like that, that you would trip over.
And definitely, yeah, exactly. Make it personalized. So if it's something that you're having difficulty with, then modify what you can in the environment to eliminate that. So whether it's walking, you know, you have a hard time with your vision, you have either a history of cataracts or glaucoma or something, it's harder for you to walk in the darker lit rooms. Why don't you add in a night light or something into the environment there to limit that risk of any additional fall. So to kind of figure out what's personal for you and what the limiting factor is for you specifically.
So Pam asks, my sneakers have thick soles than heels. Recently I've fallen while walking. Is this a well-recognized threat? Are there any particular kind of sneakers that are good for preventing you from falling when you're walking out?
I don't know.
Go ahead.
Yeah. I don't know if it's, you know, the thick sole in particular, but any type of change in footwear or a recent change in a shoe definitely takes some time to, you know, get used to and kind of make it more of a natural gait pattern or normal walking pattern. So any type of change, you know, can cause some of that disruption in your balance and your proprioceptive input. I don't know if you have anything on the sole specifically, Allison.
No, I would say, you know, there's nothing about, we don't tell people don't wear thick sole shoes or anything like that. Again, it could, like Christina said, could just be the if it was a recent change, but.
So can you give us, one person asks, 3 generic balance exercises? I mean, the ones that I remember that I found helpful was when you put one foot in front of the other. There's probably a name for that kind of walking, right?
We would call that,
it's easy to
we
do.
would call that tandem walking.
Tandem walking. Yes.
It's hard to say which ones would be good 3 general ones for everybody, just because everybody reacts differently to the balancings that we do in here. Some people, we try to do that tandem one where you put one foot in front of the other and we would have to catch them. So it really is personalized. I would say the important thing is to find out first if you have a risk for falls, and then if there are any of those modifiable risk factors, to figure out, you know, what's causing it, and then deciding what we need to do to make that easier or make that better.
So I think we have one more question, and that is, are there best ways to manage to get up from falls? Do people need training to get up from falls, and who provides this training?
So that is definitely one of the areas that we will address as well in therapy. So if there is, you know, if you have any history of falls or any even difficulty getting up for falls, we will absolutely practice getting on and off the floor in the clinic and going over the best ways for you to do that. I think, you know, from my standpoint, I would typically tell somebody to try to get to something that is stable, and then use that stable surface like a chair or a couch or a table, something that you can kind of give yourself some leverage on, and obviously making sure it doesn't move, but then kind of pulling yourself up so that you're in a kneeling position, and then going into a half kneeling position where you have one leg up and one leg down, and then into a full stand. But again, that's may not be realistic or functional for everybody. So if that's something that is difficult for you to do, then we would have to really kind of process through and trial a couple different strategies to see if there's another way to get there.
Good.
But physical therapy is the right group.
Yeah. Well, I did find, and with my primary care physician that recommended I do balanced physical therapy, because I had fallen twice within a year on the streets of Philadelphia, and I found it incredibly helpful. Really was. And I still do some of the exercises, actually, as I'm rehabbing from having my knee replaced. Some of those exercises are being incorporated into that. So it would be great if you could send us the links that you had and the information that you had on resources.
Absolutely.
or even if you're willing to share it, the PowerPoint presentation itself,
Sure.
you'd send that to either I or to Karen Charlotte. And then I want everybody to know we have recorded this session, and you will be able to access it on our website, on the ASF website. And we will send you the link to access it on the website as well when it's up there. I want to thank you both very much indeed. I know you're very busy physical therapists, and I know you had to like squeeze this into your clinical day. And we did get a terrific turnout, and I know I'm sure everybody's found it incredibly helpful. So thank you very much indeed.
Great, thank you.
Thank you.